Good morning, and thank you for the opportunity to be here. As part of the background we're providing today, I was asked to talk about evidence-based interventions, improving patient self-efficacy. And with that title given to me, I decided to take license and really focus on the cognitive behavioral portion, which I think is really central when talking about pain care. Just by way of a little bit more background, I actually work at Harborview Medical Center in an outpatient specialty clinic, our neurorehabilitation program there, where we treat people with acute and chronic neurologic and traumatic injuries. However, I think a lot of what I'm going to be speaking to you about today, even though it stems from work done in specialty care, really applies as well to primary care and population health. My goal today is to focus on these three things. First, I want to convince you that cognitive behavioral approaches are central to pain care. I want to talk just very briefly about some of the evidence base for those and what some of those are, and then really focus most of my time on the barriers and potential solutions to their integration in care. And just so we're all on the same page, I want to mention something about terminology. When we talk about cognitive behavioral therapy, probably many of you are familiar with that term. It really kind of is distilled down to what we think and what we do, and that if we can help people with pain change perhaps what they think about it, how they think about their ability to cope with it, and how they respond or what they do, their behavior, we're likely to help them have better outcomes. However, there are a lot of other terms that you may hear in your work that represent cognitive behavioral approaches, things like self-management, coping skills, mind-body, et cetera, and the list goes on. So I'm really talking about a lot, when I talk about cognitive behavioral or self-management, I'm talking about these types of approaches. Well, so why should we be focused on cognitive behavioral approaches? Well, I think everyone here knows that pain is much more than a physiologic process. It really is a product of the biopsychosocial factors. And on this slide are just some of the predictors of pain outcomes in people with traumatic injuries. And you see that not only are things such as the acute pain severity, at least in catastrophic injury, highly predictive of outcomes and chronic pain, we also know that what people think, what they expect in their recovery, whether they think they can cope, their beliefs, and what they do, how they respond, these all play an important role in how people do. And it's interesting when you look at different populations, whether it be kind of general back pain all the way to things like spinal cord injury pain, you see that there's more commonalities in the factors that influence how people do than dissimilarities. Well, so who manages pain? I think another reason it's central to have behavioral approaches in integrated care for pain is when you think about who manages pain. On this slide, you see some art by Mark Collin. There's a wonderful online exhibit of curated art by artists who live with chronic pain called The Pain Exhibit. I encourage you to check it out. And in this piece, which has on it, may be difficult to see, but a bunch of x-rays and images of people, Mark Collin says, this piece represents the frustration both on the part of the physician and the patient in diagnosing and treating chronic pain. He goes on to say it exemplifies how the patient often puts the onus on the physician to find the problem and cure it. In reality, it should be a team effort. And I think that really gets to the core of who manages pain. Although oftentimes patients come to providers hoping for a fix, hoping for a cure, it really comes down to that it's really a team effort with the patient as the primary pain manager, who really spends most of their day-to-day time managing the chronic condition. And so because of that, I think self-management is really at the core of integrated care for pain. And so what do I mean by self-management? Well, it's really the behaviors and things people do to manage not only the pain or the chronic condition, but also its impact on their life. And we know from a wide body of research on self-management approaches to chronic conditions that if you can help people develop the confidence or self-efficacy and the skills to deal with their condition and the effects across a number of aspects of their function, they will do better. And really, self-management is not focused as much on pain relief, although that often can be a side effect. or at least a reduction in pain severity. But rather, pain self-management is really focused on promoting, again, self-efficacy and participation. And I think it was best said by Dennis Turk and Winters in their Pain Survival Guide, who said, the critical question is not how or why did I get the pain, but rather, what can I do to manage my pain so that I can get on with my life? So with that introduction, I want to talk briefly about evidence-based cognitive behavioral approaches to pain. And there's a very wide and deep literature supporting the evidence, or with supporting evidence for the use of behavioral strategies in managing pain. But with cognitive behavioral therapy, or CBT, being the prevailing type of pain self-management that the most research has been done on and is perhaps best known to people working in the field. And it's rather simply built on this idea that how a person thinks and what a person does, or how they cope with pain, influences not only their pain severity, but also how they function. And CBT can look a lot of different ways, but at its core, it tends to include things like relaxation or mindfulness-based training, cognitive therapy, which it has to do with helping people identify unhelpful ways of thinking, changing kind of mindset about pain and their ability to manage it, and behavioral strategies, including physical activity. And this slide, which is difficult to see here, but it's taken from an article looking at that really tried to capture all the different types of CBT that are out there that have some evidence to them, and really points to that there's really a lot of different strategies that people often use when looking at cognitive behavioral therapy. And I think what's important to point out is that when we look at the literature, a lot of these different techniques, there's no consistent one treatment, which makes it difficult to compare across studies, but also is a strength in that it means there's many different strategies that people can use to manage pain. Now, I wanted to just take a moment to point out something about mindfulness-based interventions. They're increasingly being used, very popular, probably among your patients. You may have them asking about mindfulness-based interventions for pain. How many in here know what mindfulness-based interventions are? Okay, most of you. So I won't get into a lot of detail, but really it has to do with helping people learn and practice mindful awareness of pain and how they're responding to it, with the goal of helping them change that. Mindfulness-based interventions, again, are very popular. I wanted to point out this slide. This was something from a journal that I subscribe to, the New York Times, my favorite journal, and also probably a good place to publish. It says, "Can we end the meditation madness?" And in this opinion piece, Adam Grant talks about how he's encountering evangelists for mindfulness, and how everyone thinks it's the panacea for everything. Well, we know that it's useful for people with pain, and certainly I like using mindfulness myself, but I think it's important to point out that it's not the end-all cure-all, and that what we know is that it's pretty comparable to other kinds of behavioral interventions for pain. How are CBT and mindfulness implemented? Well, they're typically delivered, unfortunately, in one-to-one or group settings, often in person, during office hours. So there's a range in how they're done, but unfortunately, it's often limited in how people can access them. Also, they tend to be low intensity, which I see as potentially a benefit. People can find benefits from even 1 to 8 sessions. And so there's some variability around that, but it's not a highly intensive treatment in most cases. And if you look at the evidence, multiple meta-analyses and reviews have concluded that CBT is efficacious in adults and children with chronic pain. Not only does it reduce pain severity, but CBT approaches also reduce interference from pain, improve functioning, including mental health and mood. It's effective for a wide range of pain conditions, and it's also a benefit to people with acute pain. In fact, I think in underexplored areas, how can we help people with acute pain who we know are at high risk for chronic pain learn some of these strategies early to potentially prevent or decrease the effects of chronic pain? So interestingly, when you look at studies of behavioral interventions for pain, the effect sizes or the proportion who have clinically meaningful reductions in pain are pretty comparable to what you see when you look at medical interventions. For example, a recent review of gabapentin for neuropathic pain had a pretty similar rate of people who improved with clinically meaningful improvements as what you see when you look at studies of CBT. And yet I think that there's many barriers to the adoption of self-management approaches. And I'm going to talk about kind of three categories. Judy Turner and I, a couple years ago, had a chance to review the literature together and really look at barriers to adoption of self-management. And this is what we found in the literature. First of all, I think some of the barriers stem in our mindset, not only the mindset of providers, but also patients in society. We tend to focus on a quick fix. And we tend to focus on pain relief rather than functional goals or participation. And I realize many of you in this room are more focused on function and realize it's not a quick fix. But I think as a society, we still look for that in pain relief. And there tends to be more of a focus on passive intervention rather than self-management. And behavioral treatments are often viewed as an afterthought, something you do when someone's not getting better from everything else you've tried. I liked Jürgen's analogy of stage 4 cancer. I feel like a lot of times by the time they come to us as a psychologist, they're at the end stages of their coping and managing pain. And it's also something that's often stigmatized. Also, there are many system barriers, which I think our conference today is really aimed at trying to overcome some of those system barriers. But pain still tends to be treated from a medical model. And that insurance coverage tends to be better for things like medication or physical therapy than behavioral interventions. And there's really an inadequate workforce for addressing the needs of the many people with pain, particularly in primary and specialty care. And an area that I've been particularly interested in is access barriers. Working at a specialty center in a level 1 trauma center, many of the patients that we treat at Harborview with spinal cord or brain injuries are not able to access behavioral interventions for pain. And so we've had a real interest in our division at looking at ways to tear down some of these access barriers. And I think one of the challenges has been this focus on one-to-one, face-to-face psychotherapy with highly trained providers, which there just are not many of, and many of our patients can't access. And so I think there's been a number of interesting innovations that I want to turn to now for the last portion of my talk and share with you just a couple of these and then go into a little more depth on a few we've been working on in our program of research. First of all, there have been a number of interesting studies and approaches, including one by Judy Turner, the work who's taken pain self-management into retirement communities, nursing homes for people living with, older adults living with chronic pain. There's certainly been the work of Kate Lorig and the Stanford group looking at chronic disease self-management, which tends to be community-based programs. And the work of Bev Thorne, who's done some interesting work with rural Alabamans, where they've provided them, even with simple education about pain, making a difference in these rural communities. So I think we need to be thinking about community-based as much as we can. Also, I think it's been mentioned here already, we need to capitalize on technology. And I would argue that we need to not forget about the very simple but effective technology of the telephone, which is something that we all get pretty excited about, our smartwatches and smartphones and things like wearable technology, but there's really opportunities to use technology to benefit and integrate pain into communities. And so I'd like to talk with you just briefly about a study we did looking at the efficacy of telephone-delivered CBT for pain in people with limb loss, multiple sclerosis, and spinal cord injury. This was a randomized controlled trial comparing CBT and pain education. It was delivered via 8 sessions using manuals, all by phone that were scheduled in advance and delivered by master's levels or PhD level behavioral interventionists. And we enrolled adults with amputation, spinal cord injury, or MS because these are 3 of the neurorehab populations where pain is very prevalent. As many as 50 to 80% of people with these conditions develop chronic pain. And just a couple points I want to point out from this study. I'm not going to get into a lot of the details. It's currently under review and hopefully published soon. But we enrolled 188 people into this study, and all the gray states are states where we had people in our study. Interestingly, this was not intended to be a national study, but word got out about the study, and before you knew it, we had over 200 people on our waiting list waiting to get into the trial who wanted to be, and that was a pretty consistent thing throughout the trial. So I think that illustrates the demand for this type. We also had very high adherence. People showed up for their telephone delivered appointments, much better than we see when we have clinic-based behavioral interventions. And many people talked about many benefits, and very few saw any drawbacks to the telephone delivery, both from the provider perspective of our interventionists as well as from the perspectives of the patients who got the treatment. And when we looked at how many responded, we found that for CBT, about just over 35% had a clinically meaningful reduction in pain severity, and about 28.6% did in the education condition. That was our comparator. This was not significant, but we saw over time that both groups improved, and that there were other outcomes like pain interference where both groups improved from start to finish, and that these effects were endured. And I just want to point out that therapeutic alliance was also high. The relationship that developed with the patients and their therapists was comparable to what you see in face-to-face therapy. So the telephone is really a useful way to integrate CBT into healthcare. There's also been work looking at using non-psychologists such as physical therapists or dental hygienists to deliver CBT-informed care to people on the front line. I don't have time to go into any great detail or any detail about this study. I might just take a couple more minutes because I think I started a couple minutes late. Okay, Leah gave me the go ahead. I want to talk about the MS CARE study, which we are just wrapping up. It was a PCORI-funded study looking at implementing collaborative care for pain and mood in persons with multiple sclerosis. And one of my colleagues, Mark Sullivan, who is on this study with me, is in the room. We wanted to know if a patient-centered collaborative care intervention for pain and depression compared to usual care conferred benefits in treating pain and mood and quality outcomes. And so we conducted a trial with 195 adults with MS in our MS Specialty Center at the university. And this was a study just, again, based out of our specialty center. So I just want to show a couple slides. Here again, the telephone was a choice they had, and 75% of our sessions were delivered by phone, with the rest in person. And all the blue-colored counties are the counties we had reached. So our center up at Northgate was able to reach many different patients from many different regions by using technology. And we found that this was efficacious relative to usual care. At post-treatment, participants who got the collaborative care, the MS care, reported significantly less pain severity, interference, depression severity, etc. And importantly, greater satisfaction with their care, including their overall care in the UW medical system and their overall care in the MS center. And if you'd like to find out more, my website URL shares the results. Carrie Stevens later will be talking about some of the collaborative care work we're doing with L&I that I've been a part of. But what I'd like to just conclude with is that I think cognitive behavioral approaches are really underutilized, and we need to be thinking of how to infuse what we're doing in our integration with these kinds of principles. I think too few people have access to them, and we may want to think more about a portfolio, that it's not one specific treatment, but rather a variety of different types of approaches that integrate behavioral health into them for addressing the problem of chronic pain. So thank you.